We don't have pillows. This is going to be your pillow. You can be supine for me, please, start now. And a lot of times pillows in the hospital are at a premium. You get maybe 3, and they get stolen all the time. And you can steal them all the time. But let's make this his stroke side. Can you slide that one just a tiny little bit? To move him, normally we would use what in the hospital?
Bed sheets.
Draw sheet, right? So we do that. And if this is his stroke side, and it might be just as it is, rotated up here and up on his chest and sitting up there. And then depending on his tone, his head may be rotated that way. If he's got more neglect and perceptual losses and sensation losses, he's going to be rotated away. So it's like often you see patients and they'll talk to you like this. And you're over here and they're talking, and this is like not part of their body. And that's why I think NDT is great, because it asks you to reclaim and integrate as normally as possible both sides. But the downside is we can't be there all the time, so they have to learn to do it on their own. And so all of this is prep to when we actually set up the activities to get them to do it on their own. All right? But as we think about it, we can set them up in ways that encourage that movement. So first thing is, since he's already forward here, we want the scapula not elevated and not tipped forward, but we don't want it retracted all the way to the spine either. So let's say this is going to be, I don't know whose this is, this big old snuggly thing, but anyway. We were using it last time. They left it here, so I guess it's okay to use it again. And so what we typically would do is we might need to stretch it out, but you got to have the reality check of that. If you can't keep it out here, as soon as you let it go, it goes like this, then when you walk out that room, that's where it's going to go. You know what I mean? So you got to make sure that you get what you get. I mean, that you're realistic in what you act. But what you would like to do is for this to be in more extension, and the potential, because usually there's lower tone here, at least starting out. If you don't have muscle contractions here, then you're more likely to get edema. And then if edema sets in there because you don't have muscle contractions, then you're more likely to keep the edema. So we try to fight it from the very beginning. All right? So when he's in this position, then I'm going to try to put the pillow so that it's supporting, so the pillow would, normal pillow would be maybe out to there, supporting this so that this is not retracted but protracted just a little bit, but the head of the humerus, what tends to happen is that it'll be sticking up more of an anterior. So I would even say that this needs to be a little higher for him to get that to sit a little better, where it's not poking through there. Does that make sense? All right. And then what would be nice is to have 2 pillows, and then the second pillow I would put, and again, I don't know whose jacket, is this one of y'all's? So the second one I would probably put to get the elevation, and I'd use it as a block, because when he coughs or anything, it's going to do that. And so I'm going to put it here, but I'm not going to put something soft right here and tape it. So that's the suggestion some people, family members and stuff will have, because the softness acts to facilitate. Just like you don't want to put something soft in somebody's hand that has spastic grasp or is hypertonic in their hand, because all you're doing is setting up something for them to squeeze more. It needs to be firm if you're going to put something in there. So then it stops it and then tries to relax against it. All right? So if it's can you put your legs down for me? A lot of times you'll see either it'll roll out or it'll roll in. So you might have a towel roll along the way, somewhere along in here. Why wouldn't we want to put a big old towel roll under here for any patient? Because you can get knee contractures in a heartbeat. What you also have to watch is heel pressure. So if they're not moving, it doesn't take long, and you can't tell those when they first start. Who works in a nursing home here already? Is anybody? If you can't tell them when they're deep pressure like that, they have to work their way out. So they've already done the damage, and the black part of the eschar, the dead tissue, works its way out long time afterwards. But you have to be vigilant that you don't create extra pressure, because they might not pay any attention because they're not feeling anything, or they've got neglect on that side. So that might mean that you've got a pillow there, or they'll have a heel cuff or something like that to protect it. So there's the reality of that. All right, so if we go on our side, So when we bring them on their side, when you bring anybody, if they can do what they can do, have them do. So lift this leg, please, sir. And then I'll help them. Can you lift that up at all? Now, if I don't keep hold there and it's low tone, it's going right back where I got it. So just know that you've got to keep things organized. You're going to ask them to reach for the railing over here, the side of the mat, and turn your head and roll for me. Okay? Now, he rolled nicely so that I'd have another little pillow under here to get his neck in line. All right. Or a towel roll or something, because I can see his whole shoulder. You see that? I can see this whole part. Can you stuff that up underneath there for a second? Like go back and roll just on it. There we go. All right, what a lot of people will do is look like that. So if that's what happens, you roll them back, get your hand under there, the scapula moving, bring the scapula forward, roll them back. If they're not staying on their side, you take your pillow, fold it in half, stick it up under there, and let them roll back on it. Okay? You end up with like 5 pillows if you can. Then for this particular part, if they have a bed rail, then the top bed rail, usually nowadays, they're leaving the bottom rails down for safety because they found and the whole restraint issues, but it's worse like when the bed rails are down because they're up because they're climbing over them and falling. They're getting out anyway, so most hospitals that I'm aware of are leaving them down, which was news to me last year. I was like, really? I'm learning something new. Okay, this is still the stroke side. Again, if we can get this elevated, we would put like a couple pillars. We might use the bed rail. If he's too close, again, I'm going to have to pull him over to the other side. If I'm rolling him on this side, I should pull him all the way to the other side to give me room so that it doesn't end up in the railing. Does that make sense? And then ideally, from a NDT standpoint, this is the posture. But who sleeps with their arm like that, and then as soon as you yawn or whatever, it's coming here. So most people are like, they tolerate maybe that. If somebody can do, during the day for a while, have it out there, like when they're resting or whatever, that's fabulous. Or even into external rotation, which remind me, I'll show that in a minute. So we're going to switch and make this our stroke side just so we don't have to do everything else. So this is our stroke side for the last one. You'd have you could use the braille and a pillow or a couple pillows because you want to try to get it at least even and you want it protracted, and he's already set up nicely. A lot of people will be up like that. So you want the scapula protracted and not elevated, and then if possible, this at least kind of even. If it's like too much, there's reality.
So is there a preference, the stroke side on top or bottom?
Both are good. This way, he gets weight bearing, he's attending to that side, and he's got everything incorporated into one. The other way, with this direction, stretches out his scapula, right? Takes the weight off for a while, but he's still together. And supine allows a better elevation for the hand, and it's where most people are comfortable and functional doing stuff. So, but in the hospital, they'll rotate them. They have to rotate them. So they try to, for the stroke patient, you'll see this. And then a pillow down there, especially on the parts, the bony promises, right? Yeah? Okay, so I do want you guys to try that. And just, unless you have a bunch of jackets or whatever, you can just see what you can see. Talk about where the pillows would go. But I do want you to get used to the, again, not pulling here, but mobilizing that scapula out. Okay, it's really important. You're looking for this pattern, not straight against there. That make sense? All right, let's do one other thing. So you can sit back up. Thank you so much.